Have you ever woken up suddenly in the middle of the night and your little and ring fingers just feel like they're completely numb or buzzing or maybe on fire?
Oh, yeah, I have felt that.
That pins and needles thing?
Exactly right.
And sometimes it comes with an ache on the inside of your elbow. Well, it's incredibly common. But the thing is, if you ignore it, that temporary tingle can turn into something much worse. We're talking real hand weakness, even muscle loss.
That's absolutely right.
You know, everyone talks about carpal tunnel syndrome, but today we're looking at its, let's say, close cousin, cubital tunnel syndrome. It's actually the second most common nerve compression problem in the arm. And, for people who end up with chronic symptoms, the impact can be pretty devastating. So, our mission for this podcast is really to get into the anatomy so we can understand exactly where the ulnar nerve gets trapped at the elbow, why certain things we do make it worse, and what the whole diagnostic process looks like. And we really want to focus on something surprising that came up in our research, how cubital tunnel syndrome symptoms can actually mimic a much scarier neurological condition.
Yes, that's key.
And to get it, you really have to picture the nerve's journey. It's the ulnar nerve we're talking about. Everyone knows it is the funny bone nerve, right? That zinger when you hit your elbow.
The pain can go from the tip of your elbow with tingling all the way to the tip of your little finger.
So ulnar nerve travels down the inside of your arm and then passes through a narrow channel right at the medial elbow.
That's the cubital tunnel. Is it like soft tissue? What makes it so tight?
No, not just soft tissue. It's actually a really tight, unyielding passageway that is situated right between two bony landmarks, the medial epicondyle that bump on the inside of your elbow.
Okay, and what's the other bony landmark?
The proximal tip of the ulnar bone, which is basically the pointy bone at the back of your elbow. The tunnel's superficial part is a strong, tight ligament. The tunnel has so little wiggle room that if anything causes swelling in the canal or more pressure on the ulnar nerve, you can get cubital tunnel syndrome.
Right, so that is the definition of cubital tunnel syndrome, pinching of the ulnar nerve at the elbow.
That's correct. Now let's shift a bit. Let's talk about why this happens, the causes.
It's not always like a big injury, is it?
No, it isn't a big injury usually. Let us explore the main causes for this nerve compression.
Okay.
We can divide the causes into external pressures and then internal issues within the elbow or cubital tunnel groove itself.
That sounds straightforward. What kind of things?
Externally, it's often about sustained pressure or repetitive motions that basically put tension on that nerve as it goes through the tunnel,
Can you give us some concrete examples?
like the extra pressure on the nerve while playing some musical instruments.
How does that fit in?
Well, think about it. Many instruments need you to hold your elbow bent for long periods while doing repetitive finger movements.
Oh, okay.
That sustained flexion just pulls the nerve taut against the bones of the cubital tunnel. Similarly, repetitively trauma like using a jackhammer, power sanders that causes high-frequency vibratory traumas, all can eventually cause scarring around the nerve in that tunnel.
Right. The prolonged elbow flexion or exposure to chronic vibration itself.
Exactly. And probably the most common, maybe the simplest cause, just the habit of resting the inside back part of your elbow directly on hard surfaces, which pinches your nerve between the hard surface and the bones of the tunnel.
Like I am doing with my elbow on my desk right now. Oops.
Yes, exactly. Or a car armrest. Doing that for long stretches is just direct sustained compression on the ulnar nerve.
Guilty. I'm adjusting my elbow as we speak. So, what about the internal causes, the things maybe we can't control as easily?
Internally, we're looking for things that basically crowd the space inside the tunnel. This could be adhesions like bands of scar tissue forming in there or space-occupying lesions, things like a cyst.
Okay.
Also, underlying bone problems are another potential cause, like bone spurs from osteoarthritis growing into the cubital tunnel. Or even someone has an arm that bends a bit abnormally, what we call cubitus valgus deformity, that can physically narrow the passage and put tension on the nerve.
So, the nerve's getting squeezed internally or externally. What's the very first sign? What does the patient typically notice first?
Usually the first things are sensory. It often starts with pain localized right around that inner medial elbow area, but the absolute classic and defining symptom is the paresthesias.
That's the medical term for numbness and tingling or pins and needles, right?
Exactly. Pins and needles. And specifically, it affects the parts of the hand supplied by the ulnar nerve, which means the ring finger, the fourth one, and especially the little finger, the fifth. Most people say the little finger tingling is the worst.
And didn't the sources say it's often much worse at night, sometimes waking people up?
Oh, definitely. Night pain and tingling are incredibly common. Why? Because people tend to sleep with their elbows bent, sometimes curled up. That hyperflexion really tightens the tunnel and cranks up the tension on the nerve.
Makes sense.
And, sometimes patients might mention a past injury to the elbow, or they might even describe a sort of painful snapping or clicking sound on the inner side of the elbow when they move their arm.
A click, what's that?
That click is often the ulnar nerve itself actually subluxating, that is popping in and out of the cubital tunnel groove as the elbow bends and straightens. It means the nerve isn't quite stable in its course through the groove.
Okay, so this is where it gets, well, really important.
If those early warning signs, the tingling, the night pain, are ignored, the compression doesn't just stay annoying.
It gets worse, right?
It can become functionally debilitating.
What happens next if cubital tunnel syndrome progresses?
If it's left untreated, the problem shifts. It goes from primarily sensory symptoms to motor symptoms. The ongoing pressure starts damaging the nerve fibers that control muscles.
So, not just feeling, but movement.
Exactly. Patients start reporting they feel clumsy. They might drop things easily. They have trouble with buttons, keys, fine motor activities. This progresses to noticeable weakness. Also, the numbness might become constant instead of intermittent, and eventually, you can actually see muscle atrophy. Atrophy meaning wasting away of muscle. The small intrinsic muscles in the hand that the ulnar nerve controls can start to shrink.
Wow, okay, so that clumsiness, that weakness, that really pushes the doctor to prove it's the nerve. When someone comes in complaining about dropping things or weakness, how do clinicians check specifically for cubital tunnel compression? What are the classic tests?
They usually start right at the elbow, a key. Physical exam test is Tinel's sign at the elbow.
A Tinel sign. Okay, how does the doctor check for that?
The doctor gently taps or percusses the ulnar nerve at the cubital tunnel. If that tap it'll jolt like an electric shock or tingling down into the little finger. That's a positive test.
So it points right to irritation or compression at that spot. And the location is key, right? Because specific, tapping at the wrist and getting tingling points to Guyon's canal compression is a different issue entirely.
Yes, that's correct. Another really important test is the elbow flexion test.
How's that one work?
It's designed to basically provoke the symptoms by putting the nerve under tension. We ask the patient to fully bend or hyperflex their elbow and hold it there.
Like when sleeping?
Yes, it maximizes the stretch and pressure on the nerve against the bones. If after holding the elbow flexed for, say, 30 seconds to a minute, the patient starts feeling their typical numbness and tingling in the little and ring finger, that's another strong indicator of compression at the elbow.
Okay, now what if it's progressed further? You mentioned atrophy, the muscle wasting. What are the signs doctors look for that show those crucial hand muscles are actually failing?
Sure, when those intrinsic hand muscles weaken, everyday actions become difficult or impossible. There are 3 classic signs physicians check for. First is Frohman's sign. This tests pinch strength, specifically the muscles that pulls your thumb across your palm and elevate the thumb out of the plane of the palm. If you cannot make a perfect O sign with a thumb and index finger, it implies that the adductor pollicis, the flexor pollicis brevis, and the first dorsal interosseous muscles are weak. The patient can't make a strong pinch and cannot hold a piece of paper tightly between the thumb and index finger like they can on the opposite side.
So, what do they do instead?
To compensate, they cheat. They hyperflex the IP joint at the end of their thumb, use their thumb flexor to compensate for the weak intrinsic muscles. That makes the pinch look different. The perfect O turns into a rectangle, and the long finger tries to support the index during pinch.
Okay, I see. What's the second sign?
Second, we look for signs of atrophy of the ulnar innervated intrinsic muscles or the positive masses sign. This sign isn't really a functional test. It's more of a visual cue of atrophy. The ulnar innervated intrinsic muscles waste away and the palm looks flattened or scooped out, particularly at the base of the little finger.
And the third?
And third is Duchenne's sign, also described as ulnar clawing, or sometimes a sign of benedictions because of the flexed posture of the ring and little fingers.
How are the fingers clawed?
Because the ulnar nerve supplies muscles that help bend the main knuckles, the MCP joints, and straighten the finger joints, the interphalangeal or IP joints. When they weaken, the opposing muscles pull the hand into this characteristic posture, where the ring and little fingers are bent at the middle and end joints, but extended at the main knuckle. This finger posture is a sign of severe long-standing nerve damage that can cause atrophy.
Okay, let's pause here because you mentioned something really critical earlier, the differential diagnosis. You said cubital tunnel syndrome symptoms, especially that motor weakness we just talked about, can overlap with some really serious systemic diseases. What's the big one doctors absolutely have to consider and rule out?
Yes, this is crucial. The connection we really need to highlight is with the myotrophic lateral sclerosis, or ALS disease. This is a devastating progressive neurological condition, and while it's rare overall, about 30% of people with ALS first present with weakness that starts in just one arm or leg.
So, isolated weakness in the arm, for example?
Exactly. Isolated progressive weakness, maybe with hand muscle atrophy. If that's how it starts, it can look remarkably similar to severe chronic cubital tunnel syndrome.
That sounds like a massive diagnostic challenge. I mean, if both advanced cubital tunnel syndrome and early ALS can cause hand weakness and wasting, how on earth does a doctor tell the difference between a treatable nerve pinch at the elbow and, well, a catastrophic systemic disease like ALS?
The absolute key differentiator, the thing you look for first, is sensory loss, that is numbness and tingling. With localized cubital tunnel syndrome, because the nerve being squeezed carries both motor and sensory fibers, you will almost always have that characteristic numbness or tingling in the fourth and fifth fingers. The sensory part is usually there early and persists.
Okay, and ALS is different?
ALS fundamentally is a motor neuron disease. It primarily attacks the nerves controlling muscles. So the key distinction is the absence of sensory loss. If a patient has profound weakness and visible atrophy, but they report absolutely zero numbness, zero tingling, zero pins and needles, that's a huge red flag. No sensory symptoms at all.
Right? In that case, the clinician absolutely must broaden the investigation, looking for other signs suggestive of ALS, like muscle twitching elsewhere, fasciculations, maybe even in the tongue, or signs that other nerves beyond just the ulnar nerve are involved.
That presence or absence of sensory loss is often the first most critical fork in the diagnostic road.
Okay, so once that really serious differential is sorted out, and we're fairly sure it is cubital tunnel syndrome, how do doctors confirm it? What tests help nail the diagnosis?
Well, we often turn to electrophysiological testing. That means EMG or electromyography and NCV or nerve conduction velocity studies.
EMG and NCV, what do these tests show?
They're essential because they give objective proof. The NCV measures how fast the electrical signal travels along the nerve. If it slows down significantly as it passes through the cubital tunnel compared to other parts of the nerve, that's strong evidence of compression at the cubital tunnel.
Okay, that sounds very helpful.
Also, the EMG checks the electrical activity in the muscles supplied by the ulnar nerve to see if they're showing signs of damage or denervation due to that compression.
That also makes sense. What about imaging? Do X-rays or MRIs help?
Yes, they can. Simple X-rays are pretty useful for spotting any underlying bone issues. Like we mentioned earlier, osteoarthritis, especially bone spurs or osteophytes from the elbow joint, might be physically pushing on the nerve.
Okay. And an MRI can give a much clearer picture of the soft tissues, including the nerve itself, and might show swelling or the exact point of compression or rule out other things like cysts. All right, let's talk treatment. Once we're confident it's cubital tunnel syndrome, and maybe it's still in the earlier stages, is there anything we can do before considering surgery? What's the conservative approach?
Oh, absolutely. From mild to moderate cases, we always start conservatively. The first line is really about changing behaviors, basically, stopping the things that are aggravating the nerve.
like consciously avoiding prolonged or repetitive deep elbow bending, trying not to lean on the elbow, especially on hard surfaces. Activity modification is key. Any physical aids or medicines?
Yes, for the pain and inflammation component, NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen can sometimes help. But probably the single most important conservative treatment, especially for that night pain, is night elbow extension splinting.
Splinting it straight at night?
Exactly.
Since people tend to bend their elbows when they sleep, putting on a splint, even something simple like wrapping a towel around the elbow to keep it from bending fully, can take the pressure off the nerve overnight. And does this usually work long term?
Well, the sources suggest that while people with mild symptoms can get good relief, for many, especially if symptoms are already moderate or severe, this conservative relief might only be temporary. If the compression is significant or has been there a while, surgery often ends up being necessary down the line.
Okay, so when non surgical options aren't enough, or if there's progressive weakness or constant numbness, surgery becomes the main option. What are the common surgical approaches these days?
If the ulnar nerve is generally stable in its groove, meaning it's not popping out, subluxating, the procedure that's often favored now is called in situ decompression.
Okay, I get it. In situ meaning in place.
Yes, during a simple decompression, the surgeon basically just releases the tight band of tissue, the roof of the cubital tunnel. That's pressing on the nerve, giving it more space right where it sits.
So it's a release procedure. But what if the nerve is unstable or the compression is really bad?
In those cases, or sometimes just based on surgeon preference, they might opt for a ulnar nerve transposition. This means actually moving the nerve,
Moving it where?
moving it from behind the medial epicondyle bump to in front of it. This takes it out of that path where it gets stretched and compressed when the elbow bends. This transposition can be done in a few ways, placing the nerve just under the skin subcutaneously within the muscle or deep under the muscle submuscular.
Any other surgical options?
There's also a procedure called a medial epicondylectomy, where they actually shave off part of that bony bump, the medial epicondyle, to create more room. It's used less commonly now than decompression or transposition, but it's still an option.
And like any surgery, there are potential downsides, right? Briefly, what are the risks?
Yes, of course. With any nerve surgery, there are risks. The main ones include the surgery might fail to relieve the symptoms adequately. There's a risk of direct injury to the ulnar nerve or one of its branches during the procedure. You could develop a painful scar neuroma where the nerve was operated on, or something called ischemic neuritis, which is nerve irritation from temporary disruption of its blood supply during the surgery. And sometimes scar tissue can reform and cause recurrent compression.
Okay, but let's say the surgery goes well. The nerve is released or moved. That's not the end of the story, right? The recovery phase, especially therapy, seems critical based on the sources.
Absolutely, the post-op care is really where you solidify the gains from surgery. It's all about protecting the nerve while getting function back.
So, what happens right after surgery, like in the first week? What are the main goals?
Immediately, the focus is on managing swelling, getting it resolved, and keeping the fingers moving with gentle active range of motion exercises. Patient education is also important.
Educating about what?
Things like recognizing signs of infection at the incision site, and importantly, emphasizing things that affect healing. For instance, wound healing takes longer in people with diabetes and in smokers, so really encouraging a smoke-free recovery period is important.
Okay, makes sense. Then what? When does work on the scar itself start? Scars can be sensitive or thicken.
Right? Scar management usually kicks in around week 2 or 3 once the wound is properly closed and stable. This typically involves starting gentle scar massage,
How do you do that?
using a bit of lotion or maybe vitamin E oil cream, doing light circular massage over the scar for, say, 3 to 4 minutes twice a day. The goal is to keep the scar soft and prevent it from sticking down to the tissues underneath. Sometimes scar conformers like silicone gel sheeting are also introduced too to help flatten and soften the scar.
And what about getting the rest of the arm moving?
At this stage, around 2 3 weeks, gentle wrist range of motion usually starts too. always keeping it within a pain-free range. We're still being cautious.
Got it. So when can someone expect to get back to, normal life, lifting things, playing sports, doing heavier work? What's the timeline?
The key instruction patients get is to really limit any forceful activities. No heavy lifting, no strengthening exercises, no strenuous tasks until about 6 weeks after the surgery. 6 weeks minimum.
Okay, at that 6 week mark, assuming things are progressing. Well, light strengthening exercises can begin. Gradually increasing is tolerated.
In general, the goal is to return to full unrestricted use of the arm and hand, including sports and heavy work starting somewhere between 6 to 8 weeks after surgery. Return to heavy use should be gradual to avoid a flaring up that causes swelling and irritates the recently released nerve.
Okay, let's try to wrap this up and pull up the main points. If you had to give our listeners just two key takeaways about cubital tunnel syndrome from this whole deep dive, what would they be?
Okay, two things. First, just remember how common cubital tunnel syndrome is. It's the number 2 compression neuropathy in the arm right after carpal tunnel syndrome. It's not obscure. Second, really understand the progression and its consequences. Those early sensory symptoms, the tingling, they're a warning sign. Because if it becomes chronic and severe, the hand weakness becomes the biggest problem. And this is critical that weakness might not fully resolve even if the surgery successfully decompresses the nerve. Muscle recovery can be incomplete if the damage was prolonged. That functional loss, losing the ability to use your hand properly because those little intrinsic muscles have gone. It's a really serious outcome to think about.
It absolutely is. And, what's really fascinating and maybe a bit unnerving is how that end stage picture of severe cubital tunnel syndrome, the significant hand weakness, the visible atrophy, can look almost identical at first glance to how a very serious neurological disease like ALS might present. Which brings us back to that crucial differential diagnosis.
Exactly. So here's a final thought, maybe something provocative for you, the listener, to consider. If you started experiencing really noticeable isolated weakness in one hand, maybe dropping things, feeling clumsy, maybe even seeing some muscle atrophy, what's the single most important additional detail you'd want to know? The answer is the presence or absence of sensation in the ring and little fingers. The answer helps you think about whether this is a localized, treatable nerve pinch at the elbow versus something more serious. If that sensory loss is there, you lean towards cubital tunnel syndrome, the treatable compression. If it's only weakness with absolutely no sensory change, alarm bells should ring and you need to think about a much bigger picture neurologically.
Well, that's a really important distinction. Well, thanks for walking us through all of that fascinating and clinically really important stuff.
We hope you have enjoyed this hand surgery resource podcast on the cubital tunnel syndrome provided by the International Federation of Societies for Surgery of the Hand, the IFSSH. For more information on cubital tunnel syndrome, check out our hand surgery resource app at the Apple Store or at the Google Play Store, or sign on to our website at www.handsurgeryresource.net. Thank you for listening.